GLP-1 drugs, a highly effective treatment for obesity, the first time we've really ever seen that. They're very exciting, they're producing a lot of benefits, they're also very expensive. And so there's a lot of questions about how much do they need to cost, who should pay for them, how do we make sure that we're getting good value out of them. And so that's why I'm glad that we have this really interesting panel here to talk about all of that. I'm with Lisa Stevens, who is the Chief Administrative Officer at Aon, who has some interesting insights to share with us, looking at both the population of tens of thousands of employees at Aon and tens of millions of employees whom Aon has insight into employee benefits for. Simon Johnson, Professor of Entrepreneurship at MIT Sloan, also a Nobel laureate in economics recently. Congratulations, Simon. And finally, Michael Farrow, who is the chairman and CEO of Merrick Ventures. He's a healthcare technologist. You may know him as the founder of eMed, and has some interesting insight for us on adherence and getting people to actually stay on these drugs. So I want to start with Simon. As we think about scoping, large benefits, large costs here, what are we looking at in terms of the universe of benefits that we as a society are getting and stand to get out of this class of drugs?
Well, I think Dr. Oz actually hit a lot of the key points just now, Josh. Historically, when people's health improved because of better public health and also better private treatments, they became more productive, they lived longer, their children, they got to see their children grow up, so you don't have a problem of dealing with orphans and so on. There were big social benefits to health improvements. Unfortunately, where we find ourselves now is we innovate very effectively in the United States. We invent a lot of new diagnostics and treatments, but the costs continue to rise. And the costs are borne by private employers, they're borne out of pocket, and of course by the government. So Dr. Oz was talking about Medicaid expenses continuing to rise. And what GLP-1s offer is the possibility, maybe probability, we're going to talk about that, maybe high probability, that this cost curve could be bent by decisions that individuals will want to take, that companies will want to take, and that government may want to lead on, may want to emulate, and so on. So we could be back into a phase where health improvements lower our costs, healthcare costs, lower the burden of those costs, make us more productive, and have really massive social benefits.
Well, that would be very exciting. How close are we to that? Lisa, what's your take on that?
So there's been a couple of different panels today that we've been able to hear, some people have been able to hear about, but at Aon, we spent a lot of time looking at analytics and data. And so to complement this, one of the things that we've looked at, because of our clients having so many questions about GLP-1s and the use of GLP-1s and the cost, and we heard it again from Dr. Oz, like trying to navigate what benefits you provide to your colleagues, your employees, it's a big question. And so we have a database of 50 million people that are in businesses. So over 60% of all people are insured through their companies. So we believe, and I'm sure all of us do, that employers play a big part along with the government in making sure that we make healthcare available to everyone, not just to the wealthy. And so in this database of 50 million, we found 139,000 people who've been on GLP-1s for 2 years and adhering to it. And then we had a digital twin, so a control group of another 139,000, and matched them up. And no surprise, in the beginning, when you're first on a GLP-1, the cost goes up. The cost of the drug, all of a sudden you're starting to feel better, and you start going to the doctor. And so the expenses you see, so it starts higher, but then as the year goes on, and when you go into the second year, you start to see the curve bend. You start to see health improvements. 44% improvement in cardiovascular issues, improvement in less osteoporosis. The list goes on and on of things. There's been benefits that we've seen from the data. And so there's a return on investment, but it takes time. And so what we're trying to do is help our clients navigate through this, make decisions about this benefit being available to their colleagues, to their family members, to create a healthier America, to create a healthier environment. And this doesn't even take into consideration absenteeism, productivity, engagement. But the holistic approach is also really important. And so that adherence piece has been something that we've been paying attention to.
Yeah, so you say 139,000 people who have been adhering. There's all sorts of reasons that people go on these drugs and do not continue with them. Michael, what are you seeing? Because that's really a key space that you're in here, is trying to track and improve adherence on these drugs. what does it take to actually get people to not just go on this for a few months but to actually stay on it and get persistent health benefits from that?
Well, the first thing is accessibility, making sure right now GLP-1s are a rich person's drug. There's bad behavior everywhere. Even the counterfeit drugs that a lot of people have been taking are still $200 to $300 a month. So right now this is a white, rich, urban medication, and it's not getting to the vulnerable populations who really need it. And so the first step is accessibility. We need the government, we need third-party sponsors such as corporations to put programs together. Now, rightfully so, like you said, the average GLP-1 user on the planet is in it for 90 days, 50% quit. And the reason for that, first of all, one is cost, accessibility to the drugs, and the next one is things like side effects. So the first thing we did when we founded eMed, when we were working on COVID with Abbott the last few years, is we built this system that helped keep people on medication adherence by having a system that allowed people very inexpensively access healthcare 24 hours a day with no scheduling, instant access to life care. Now this is important. If you're gonna have a drug like GLP-1s that are a medication for life, let's first start with that. I hear people talk about this all the time. Is it 12 months, 3 months, 6 months? No, all the on-label is that this is medication for life that needs to be titrated every 30 days. So the first people do is they're not...
But so just to scope that's how we should be thinking about this? There are...
Like a statin, if you have HIV, you're going to be on drugs for life. If you have a heart failure, you're on drugs for life. Mm-hmm. Obesity right now, the number one problem with GLP-1s in the world and getting reimbursement, I'm going to tell you the number one problem. Dr. Oz's ex-partner, still partner, Oprah Winfrey describes it very well, obesity discrimination. The number one problem with people being on GLP-1s around the world is half the population believes obesity is a disease. But then we have the other half that thinks work out more and eat right, you fat person. And it's obesity discrimination. And that's really the biggest problem facing people being on this program. But the people who do get on the program, to your point, why do they leave? Things like side effects. So at eMed in the UK, we launched in December. We have over 25,000 women who voluntarily get screened first with a little dose. They have to take a little screen of blood at their home, which we oversee for them, send it to see where they're at in cholesterol and kidney, thyroid function, et cetera. And they voluntarily did this. We thought we'd have 10,000 people in our study. They have to pay $200, about 160 pounds a month, to be honest. We thought we'd have 10,000 participants. We had 31,000 apply. We currently have 25,000 on it. And here's the great thing, when you have something simple where you give them a reduced cost for these miraculous drugs. We have 98% retention, 9-8. It's 99 if you take out people with pregnancies because we have to push them off for non-voluntary reasons to leave. And the reason is access. They check in every day. They have their blood work to know that it's changing them biologically. It's less money. And right now, so you know, GLP-1s are more popular than cocaine in the world. They cost more too in some places. But they're more popular. And when you have this miracle drug that is the first preventative health product that people actually want, it is the first product in our lifetime that consumers around the globe, from America to the UK to Saudi, want this product. And it's about preventative health. It's about bending the curve. It's about wellness. We've never had this happen before. We have to take advantage of this.
The one thing, everything you're saying, I agree with. I do think employers play a key role in this, right, in terms of accessibility and the opportunity to provide it to a population. So 40% of America right now is dealing with obesity. It's a crisis. It's an absolute, it was mentioned again on the panel right before us. And so employers having data information to be able to, again, have their employees be part of this, be able to find ways to help them to adhere to it with diet and exercise. It is a next generation solution, as we see right now, for a healthier America.
But so the funny thing about this is already a really expensive phenomenon. This has been a significant driver of healthcare costs in the U.S. just over the last few years, despite the incomplete accessibility. and the incomplete adherence. And so if you get better at getting people to adhere to it, and if you overcome some of that stigma, and if you bring in to employers the idea that this is part of a holistic healthcare package, then it gets even more expensive, right? Are we talking more than $5,000 per patient per year on this? It's got to be more than that, right?
So and I'll let Lisa talk about this. So in the UK and even here in the US, if people actually stay on the medication, do medication adherence, your costs go down.
On net, they go down by more than the annual cost to be on the drug?
Yes, your overall costs go down. I don't have the Aon study in front of me, Lisa, but I think it was 7%.
So, correct.
7% improvement in your overall, because this population, as they go down.
But so 7%, I mean, what's the average healthcare cost per employee for someone who has commercial coverage? I mean, to overcome, if it's even $5,000, now that sounds a little light to me. Does that employee on average have $60,000 in healthcare spend?
So let's flip it a different way. Right now, and again, Milken data, we're spending $1 trillion a year on obesity, different types of diseases, which make up over 60 diseases, right? So if you think about the problem, and then you say there's an application to it that we have that can be, again, a holistic solution where you're going in, and in the beginning, again, the cost is higher, but over time, you bend the curve. You start to see the employee having less issues around, the human being having less issues around, again, cardiovascular issues, osteoporosis, pneumonia, diabetes type 2. So there's still a lot more to be done, but the data is showing us that the return on the investment is absolutely there. You have to get past it. The last thing I'll just say is we have, again, clients who they've been offering GLP-1s to their employees, trying to figure out, do we keep doing it into 15, 18 months? They need to have the data and the information. This is what Dr. Oz was talking about, to understand, do we continue to do this? Because it's going to start to pay off. And so that's being able to provide that information and data for them to understand the claims and understand what's happening with their employees will actually, in the long term, be a good investment and will bring the cost down.
Simon?
Yeah, so 2 points, Josh. Obviously, the amount we pay up front is going to affect the payback period, right? But the key thing, the really dramatic thing, and the new thing is the curve changing its shape. That's the bending the curve idea, right? So that we can see. And presumably what will happen, Josh, I mean, this we're good at in the US, is as this sector expands, and if it expands dramatically, if people really understand adherence, you'll get a lot more entry, a lot more competition. It won't be an injection anymore, it'll be a pill. And Michael's point is, it's like a statin. Well, statins, there's plenty of competition. If we find the right statin for you, you can stay on that statin for a very long time. It's good for you, and it's extremely cost effective in terms of, that gets driven down to the cost of manufacture. So the dynamic, I think, is what's got our attention here, Josh.
But I have a question to go to next, but first I just want to flag for the audience, there's a QR code that they can bring up on the screen here. If you have questions, scan that QR code. You can send your question in. I'll receive it on this iPad right in front of me here, and I'd love to take some of your questions as part of this conversation. And so with that longer run benefit and the longer run cost picture, do we have a sense of, if these drugs, they were listing for $1,300 a month, but maybe a year ago, they've already started to come down. Zepbound, I believe the list price now is like $550 after consumer rebate per month. That's still substantial. That's still over $6,000 a year. But there's going to be more competition, maybe more entries, maybe pill forms. Do we have a sense of 5 years out from now, are we going to be talking about something that's half as expensive, that's 1/10 the price? What are we looking at in terms of a medium-term cost here?
They're all coming down right now. Both Novo Nordisk and Eli Lilly have announced plans. We're working with both Novo Nordisk and Eli Lilly to have plans, working with PBMs to get the cost down for the corporations that have programs that have auditability and accountability, so the employers and the PBMs and the payers all can see a return on investment. So one of the reasons people have a problem right now is that they're going to have to cover. So there's no way not to cover GLP-1. So most people in the audience, so GLP-1's been around a long time. If you have type 2 diabetes, by law, you're getting covered. But guys, there's new indications that they're going to have to cover for things like liver disease, kidney disease, cardio, sleep apnea. There's another 7 on that the employers need to just manage this. It's too late to say, we're not going to cover GLP-1s. I'm like, well, you could say you don't want to cover GLP-1s just for obesity. But right now, Dr. Deanfield out of the United Kingdom just released a report, and maybe you can go get, that his perception, his study on people on GLP-1s is that it doesn't matter if they lose weight. This is really important. GLP-1s, because of their anti-inflammatory effect and the way they help you digest things like glucose, are changing the health curve right now for anyone on it, where losing some weight is nice, but it's actually biological changes. So in the UK, the drugs are a lot less expensive for the branded drugs. It's about 100 pounds a month for the drugs in the UK already. So I can't tell you what's going to happen in the US, but I see it going in that direction for all the drugs. But the real issue, no matter what, is making sure that it's accessible. So our CEO is Dr. Patrice Harris. She's not here today. She's the former CEO of the American Medical Association. And part of her thing, she's our co-founder, was how do we make this accessible to vulnerable populations in the US? And she's working with government officials and the manufacturers to help get this so that we can do remote GLP-1 management. How do we get to these people who need it the most that make the biggest effect?
In our data, we didn't take the cost of the drug into consideration. So we were purely looking at, again, what was happening along the 24 months of the 139,000, and where were we seeing the changes, again, against the control group, against their digital twin, and the improvements in their health over time. So taking that out and looking at, okay, so what are the benefits? And that's where you can help the employers to make that determination of, does this make sense for us, for our population, with being able to provide the access to it, again, with the adherence and with a wellness program tied to it.
Simon?
Yeah, I think there's a very important question coming for state Medicaid programs.
I don't know what this biplane is, but...
I'll shout.
Sorry, yeah.
So state Medicaid programs, I think, have a very interesting proposition before them right now. Which is that they're dealing with a lot of people who have many of these comorbidities that Mike was talking about, and this is a very big cost which is borne by the state and is also shared with the federal government. If they can get access to these medicines at a cost they think is reasonable, then they have the potential of extending lives, making these people more healthy, and actually having them survive until they're eligible for Medicare, for example. And that's a pretty big, I think, motivation for the states to think about this. And of course, that's very vulnerable populations that we're talking about.
Well, there's a new effect, too, that I was talking to Dr. Oz about a few months ago, before he was confirmed, is that if organizations, governments included, tell people, hey, we want you to get screened to get this medication, to get this reduced cost for this miracle drug. Now, here's the issue. We would love to get everyone screened in every country because, as you know, screening people, you find things. So let me tell you, real data. Of the people that voluntarily screen right now, 3% of them have critical issues that we find in their blood work that we need to send them for immediate care, 3%. 91% of both US and America have other comorbidities besides obesity. But we find things like thyroid issues, liver issues, people had no idea. If we can start people to do screening, inexpensive at home, taking basically a physical, giving a little blood work with about 10 panels, if we can start doing this in countries all over the world, from the UAE to Saudi, we're in talks with, to India, that will bend the curve just because people starting to do any type of preventative medicine is a big change for population health. This is the first time we've had this opportunity. In America and other countries, they've been trying to pay people to go do a checkup, and it hasn't worked.
So one interesting thing about this idea that you have costs that start high up front and you produce benefits in health that maybe over a lifetime and or certainly over a period of several years is that you have a question about who pays and who benefits. So if you have an employee and you're paying for a GLP-1 drug now and they're going to be healthier in 5 years, they might work for somebody else in 5 years. That's a different payer who's going to be saving money there. You also have, if there's a lower disability burden and that saves the government money and the government's not the payer, that's a fiscal benefit, but the fiscal cost is not there. You can also get the reverse version of that. You have someone who is a Medicare or a Medicaid patient, you have a government expenditure, you have certain privately captured benefits. I'm interested in all of you, but especially to start with Simon on this. What does that tell us about, should we be thinking differently about who should pay here? I mean, is this something that should be, is this a fiscal cost that should just go on the government because of the really long-range nature of the benefit?
I'm laughing, of course, because this is the kind of, the question that would kill initiatives. Trying to change the payment structure in the US healthcare system is very, very difficult. I think, Josh, what's interesting is that, sure, we could probably come up with a better scheme. Give us 20 minutes. But working with what we have, you can see agency for individuals, you can see motivation for companies, you can see state Medicaid agencies and authorities wanting to get involved. And so I think there's a path forward that may not be ideal, may not be as fast as we want, it may not drive as much innovation as quickly as would be ideal, but I think it's a preventive type of program that people are opting into, and they're going to see benefits immediately as long as they adhere to it. I mean, the adherence, I think, is the key thing that we all want to be stressing here today. If you don't adhere, you incur a lot of costs and you don't get any benefits, and then you get a backlash against this kind of program.
Lisa?
So it's a fantastic question, right? So as an employer, so as the head of HR for a 66,000 person organization, having data and information to make the decisions about what benefits are you going to pay for? What do you need to offer to, and what helps with retention of your employees too, and longevity of your employees staying with you? And so those are the right questions to ask. And so for us at Aon, we made the decision to provide GLP-1s to our employees in the United States and their family members. And we believe that we will have a healthier workforce. And we do believe that you have to have adherence, which is why we're partnering with eMed to help us with the adherence for our colleagues and their family members. But I do think that data and information depends upon the organization, like you said, and so I'm speaking directly about employers to really determine that. And it goes back to where do you make your investments? And one of the things that we have that we've used and we use inside of Aon also for ourselves is we have a health risk analyzer that helps you determine what are your claims inside of your organization to determine where is the best place that you should be putting your benefits towards to have a healthier workforce, again, to get that return on investment. In this case with GLP-1s, we see it as a next generation opportunity for us to create a healthier workforce inside of Aon.
So I've actually heard this from HR. Your exact question.
Yeah.
Hey, we have people who leave. Why should we do this, et cetera?
Right.
So first of all, let's just be in a financial thing. Recruiting people is very expensive. And I've told everybody the cost of doing a GLP-1 program, once again, you all have GLP-1 programs. You all have them. You just don't know it. Because everybody can go to their doctors. The big thing that's happening is doctors can write scripts. If you don't have a controlled program, you have an out-of-control program. But you all have it. But here's what happens. People put a value now. With compounding going away, you all have a giant issue the next 90 days. I'm going to explain this to you.
So I assume most people...
You know what compound counterfeit GLP-1s, like you've seen them, the $200 to $300 a month, where a lot of your employees today have been like, I'm just going to go pay $200 out of pocket and go on a program. I don't know if it's fentanyl and sugar water in there, but I'm still going to go do it. There's been hospitalizations and things over these counterfeit products. But here's what's happening. Get excited for Q4, guys, because all the compound counterfeit drugs are running out. And there will still be bad guys making it.
There was a change in the FDA regulation.
FDA regulation.
It was allowed and now it's not allowed.
To not allow this anymore. Mm-hmm. Well, guys, people are going to be like, even with all the price reductions, it's going to cost people $600 to $700 a month to go do this. Just so you know, if you have people who make $100,000, this is 10% of their pay. They still want these medications, and they're going to go to an employer that does this medication. People don't understand. I'm talking with Aon and other benefits consultants. There is a traumatic thing that's going to happen this summer and fall when all these employers that need employees need help. And to some of them, this is the most, go on TikTok, go on social media, go see people who are doing GLP-1s and how it's changed their lives. For the first time, food noise, being able to wear clothes, go on vacations, have relationships. You all have 1.5 million of those people coming to see you saying, I can't afford it. What are you going to do? What they're going to do is this. I've told this to Novo Nordisk and Lilly. I'm like, they're going to go find ways to either go get more dangerous, back alley, black market products from China to try to stay on it. If you don't help them, you're going to have sicker employees, or they're going to go find an employer who takes care of this because they look at it as a $10,000 a year benefit. So you need to make it that it costs you $5, get the credit from them, even if it's for seasonal workers. Some companies are talking about getting seasonal workers with this promotion this year. We cover GLP-1s because it's that important. It is the number one thing that I've been hearing from every CEO, CFO at their companies. Aon's explained this to me, Gallagher explained it to me, other people have explained it to me today. You all have an issue. You need to figure out how to manage it. It is a tsunami coming. Now, what they think is going to happen at Novo Nordisk and Lilly, great companies, they just believe people are going to suddenly find $600 a month out of their pocket and pay for it. They actually believe that. Maybe they're right. Maybe people are going to give up their car, less food on the table, maybe move into a smaller house. But that is very hard for most Americans. Spend $600.
I want to ask about a couple of areas of the benefits and the costs that people are trying to scope here. One is, Lisa, you talk about the reduction in healthcare costs. But people are looking for a broader set of benefits beyond just healthcare cost improvement. There's this idea that you'll get higher productivity, fewer sick days. Of course, then there are subjective benefits to the consumer also, which I think are difficult to measure. But are there numbers that you can start putting on if your employees are on GLP-1 drugs? Not only do they save on some of their non-GLP-1 healthcare expenditure, but are they showing up to work more? Are they doing better work?
So we're way too early into offering it. When we started in December, and our population numbers are small. It's our U.S. population, so it's not large enough.
Right.
What I will say is that we're looking at, have been way before GLP-1s came out. We've been looking at the mental health of our employees, which is, you couldn't even say the word mental health 5 years ago. We're looking at the mental health, physical, emotional, financial, all of those things, and we're measuring it. We're measuring how are they doing, because we know you have to pay attention to the entire employee. We also know that this generation expects very different things from their employers than before, and so the intention on how and what we do, and then measuring it, is super important. And same for any employer. So you can talk about AN at 66,000, but we're helping companies all over the world with millions of employees and trying to determine, again, where do you shift your costs to be able to have the most productive, engaged workforce you possibly can.
Simon, how do you think about measuring that? Because again, these are big fiscal questions when the government is deciding, are we going to cover this in Medicaid? To be able to put a number on that, I think sort of helps people figure out what's worth spending money on.
Let's come to the fiscal question just a minute.
Sure.
I think that this measuring the productivity gain,
yes,
not just the engagement, not just sick days, but also Michael's thing, which is like the person is massively distracted, the person gets engaged in high-risk behavior, you lose the person. I think that's the frontier, and that's what a lot of people are working on right now, Josh.
Right.
That's a really important number. We don't know for sure. We know the sign of the effect, but the quantity is going to matter.
Yeah.
In terms of the fiscal effect for government, this is, I think, a related but different calculation, because from the state Medicaid point of view, you want people to be healthier for longer. You'd like them to get off Medicaid and have a higher income, obviously, to do that. So productivity is going to be related. But you definitely want them to live to be healthy enough to go to Medicare. Now, when you think about it from a Medicare perspective, so Dr. Oz is looking at both. He's got a very tough job there. Medicare, I think, is also going to benefit from this. Again, the question will be, is it a 45-year-old who is less sick, lives now to be 65, 75? At the end of your life, Medicare still owns a lot of that cost, right? So that's not going away. Let's not kid ourselves. And, Josh, there's going to be implications for Social Security.
Right.
We have to confront, and we have to think about that. People are going to live longer, happier, healthier lives. That's a good thing, for sure. But they're going to need to draw on Social Security for longer.
The sign on that fiscally, I think, is uncertain, right? Because if people, if extending life adds Social Security costs, but maybe we also extend their working life, and that actually improves. How are we going to measure that? Is there a way how do we develop a view on what the sign is there?
That's going to take longer. And obviously what's going to happen on the working life is, what do people choose to do? Now you're healthier at age 62. Do you choose to work to 72, Or do you choose to retire early and enjoy your 60s in a different way? That's a calculation we just haven't seen play out yet. But this is presumably, again, another frontier for research.
I want to put some practicality to. We've talked some about the importance of adherence. What does it mean in practice to improve adherence there? Michael, you told me something interesting before the panel, which is that as expensive as these drugs are, a lot of the cost is actually in the management around it in terms of doctor's appointments and labs and that sort of thing. What does it look like to try to keep someone on these drugs, and how do we do that in a more cost-effective way?
Well, using AI products and telehealth products and doing things remotely is one of the biggest cost reductions. So both in the UK right now, one of their biggest issues, they have the cheapest GLP-1 drugs in the world. And they came out with a study, I think Lord Darcy's here, I heard, so I've got to go see Lord Darcy, where they said it will take over 100 clinical hours a year to manage someone on GLP-1s, because they have to go get screened, see a doctor, monthly clinical checkups, buy screenings, dealing with side effects, all these issues that happen. And we said, well, if you use AI, use a platform, use telehealth, use asynchronous healthcare, we have the costs down to about 12 hours of management, and people are getting the same level of service. The other issue that comes about is the amount of time it takes people right now today in the United States of America. It doesn't matter how wealthy you are. You go see your doctor, you have to go to Quest Labs to get your blood work. These all takes hours. You then have to go find your drugs for the most part, which is another fun thing, to go find if CVS or Walgreens has them. Take your time out, make sure you're getting your prescription every month. It is a very hard system with all the money in the world. So we figured out the way to keep adherence is not just making sure they check in once a week, but you have to get rid of all these friction points to make sure there's cold storage, the cold chain where this needs to be refrigerated, like the vaccines and all the COVID products were. So this is all built now, that you need to get people home delivery with the product. They need to get it ahead of time. They need to have titration being done. No one can be on drugs for life if it's really hard. It doesn't matter who you are. So it's not just about them now, the accountability of them checking in 2 to 4 times a month, doing a screening at home every 6 months. They're willing to do that if it's subsidized. By the way, they're willing to do that if they just like the program in the UK. If this makes what's really important is what we think we're doing for third parties, that we're the only company in the world that if you're going to do GLP-1s with the eMed AI platform, we make you do a blood screening where you have to do 10 labs to begin with. And at first everybody's like, why? I've heard this from the CEOs of Lilly and Novo Nordisk, because they think that creates friction. I go, creates friction at the beginning, but it keeps them on for life, because the moment you have a report card, you, not just the company or your sponsor, of biological changes that are irrefutable, that are happening, that makes you stay and do medication adherence. Once you get your own report card, and that's what we're finding. What looks hard at the beginning, you get people through it, that changes everything. And by the way, that's the report card Dr. Oz and President Trump need too. If we're going to do this for Americans, I am very supportive of the administration's they blocked it being approved right now, the way they were going to distribute drugs in the classic way, and they're trying to figure out a model to have accountability, and we are supporters of what the government's doing.
Lisa, what role are employers thinking about taking in this when they're, are they assisting with access? Because I personally, I've been on Wegovy for almost 2 years. And the amount of hoops that I jump through for that, on the phone with pharmacies, on the phone with payers, and the price, 1 month it's $1,300, the next month it's free. The next month the insurance plan has changed over and the doctor's office has to file all the same paperwork again. Then the pharmacy doesn't know how to fill it and get the right payments from Novo on top. And so it's the amount of friction that is there, I'm sure, is causing a lot of people to drop off, either because of the amount of work that it is, or because it's impractical for them to not know what the drug is going to cost from month to month. Are employers playing a role in easing that?
So, and the data, again, that we shared on the 139,000 were people that adhered to it for that whole, the 2-year time frame. So, and like you said, the hurdles and the challenges. So I'll talk about Aon, because our experience before we changed our program, and I'll talk about a little bit more about what Michael did, but all those things are true. Like the hurdles that people would have to go through, getting an appointment, getting a prescription, getting the right dosage, dealing with the side effects, dealing with the challenge, the mental health challenge, all the things that go on in that. And so we made the decision in December to roll it out to our colleagues again in the United States and have EMED help us with that. So it's the weekly check-ins. It's making sure they're taking the drug, but it's much bigger than that. It's much broader than that. It's constant communication on here's what's happening in your body. Here's things you need to understand. It's wellness programs. It's ideas on things to do. And then Michael, I'm going to pitch back to you though on this, that I think our objective is that we're a community supporting our colleagues and their family members to be healthier, and we believe they'll be more productive as a result of that, abstinence and all those things. But one of the things about SheMed, which again is B2C, very different than the what employers are doing, but is the community that SheMed has created. So I think about the people that were taking the drug before we had the program at Aon, and they didn't have the same navigation. One of the things that I've been so impressed with SheMed in the UK is that they've created a community for these women to be able to talk to each other about the things that they're going through, and then have doctors that are coming in and providing them. That's the power and the good use of social media, Michael, that I think is very impressive in terms of an impact on why you've had, I think you said 97% or 98% of people have stayed with the program.
Mm-hmm. Well, SheMed's being run by a couple of 20-somethings that are doing it, and it's a brand we're going to bring around the world. From EMED is our SheMed brand, and EMED's coming too. Where we quietly, work with a certain gender group and figure out what their fears they have. What we found when we did a trial at EMED on GLP-1s in the UK a year and a half ago is that we just launched them to get 1,000 people on board. It was 87% were women that wanted to do GLP-1s, and that's how SheMed got launched. And now, once you said something about congratulations, by the way. So,
thank you.
Can I ask you? So, how has been your experience on GLP-1s?
I mean, it's great. I'm 30 pounds lighter, and it's like the mental effects are crazy for me. It's like it's funny. Amy Schumer has this bit where she talks about that. Women will say to her, "Oh, I forgot to eat lunch today." She's like, "I've never forgotten to eat lunch. What I have done is eat lunch at 2:30, forgetting that I already ate lunch at 11:45." And like that was my relationship to food, and it completely changed. Like I actually now have this experience where it's like, oh, it's 1:30 in the afternoon. I haven't eaten anything today.
Would you mind if I ask you a question of your titration? Do you know what level you're on right now?
Yeah, I'm on the maximum Wegovy dose of 2.4.
They're going to go up with that.
Oh, really?
They're planning on coming up with that on Wegovy to help be competitive with that. It's coming very, very soon.
Yeah.
That Wegovy will be available at higher doses, same price.
Yeah.
So I was there at Novo Nordisk last week with their team, so that's coming. I mean, it's like, by the way, that's the story I constantly keep hearing as people are on it. But the other story I hear is, so I was on the drugs, except I did my blood screening and I have a thyroid issue. So I had to get off of this little EMED test. I thought it was wrong. I was demoing it for people like you, and they sent to the results, and it turned out I have to get off the medication until they fix my thyroid. That's okay, by the way. That is good when that happens. This has happened to multiple people who, while they're trying to take GLP-1s to look better, I'm obviously obese, and I'd love to be less obese, but that's one of the problems I have is I can't be on the drugs right now. But that's okay. You're going to have that in your population. But the thing about the $1,300, I, even being the founder of EMED with Access, was paying about $1,300 a month for the drugs. And I have United Healthcare's coverage, and our company finally, we started offering to employees, and we have to make it a supplemental benefit at our own company because we can't work, the PBMs don't want to work on this right now. So I can't imagine a world in 2 years with people like Aon who are going to go help companies get over this game everyone's playing, which there's been bad behavior by the users going on and off or giving them to their cousin and not taking drugs or reselling them on Craigslist. That has happened. I agree. So we can fix the fraud. But when you suddenly tell people there's $100 to $200 copay, and you make it that they're just getting the drugs, and this is just swept out of their paycheck, and they know it comes every month, and we stop the games, I can't imagine the benefits there's going to be in the United States where suddenly Robert Kennedy, doesn't have to be as stressed out as if in 2 or 3 years, and I think it's that soon, we can actually bend. Imagine if all the benefits consultants, all the big companies in the government worked on this. During President Trump's term, we could literally stop every year. The cost of healthcare has gone up. Just imagine if we stopped and we bent the curve in 3 years. Just stopped it. How that'd be so different for all the problems we have, shortages of doctors and nurses and costs in America and fraud. Just imagine if we just make it easier and have everybody participate in the cost, but everybody do the program right. That's why that's why I'm doing this, guys. I've been a very lucky fellow. I've had lots of successes. This is the first thing, we have a Nobel Prize winner on here. You did not happen to mention that, but Simon is a Nobel Prize winner. But I think there are people winning Nobel Prizes for the miracle of GLP-1s and how it's going to change the world. It's that big.
I want to take some of the questions that have come in from the audience, and one is a question that I think we hear a lot, which is, shouldn't we be focusing on the root cause of obesity instead? It's clearly a lifestyle and dietary issue, not a GLP-1 deficit that causes it. Is it more economical and healthier to address lifestyle rather than cleaning up the mess after the fact? And so, in terms of effective, it's easy to explain to people that if they exercise more and eat less, they will be lighter. Are there effective interventions that actually change at a population level the rate of obesity without medication like this?
So, 2012, obesity it's a chronic disease. And I'm going to go back to the statistic, the Milken statistic of we're spending 1.7 trillion a year on obesity issues. And back to where Michael started with the stigma and the shame that's associated with obesity, which I think it's important that we provide people with facts and information. What we've seen, again, it's just data, but the data that we're putting in front of our clients is that, again, 139,000 people against a population of 50 million, a digital twin matched up against it. In year 2 of being on the drug and adhering to the drug, with diet and exercise, it's a generational change for the world. And so far, that's what we've seen from the data.
Simon?
We don't see this about statins.
That's
right,
what
Josh.
right.
So you could just say, you can lower. I said to my doctor, don't worry, I can lower my cholesterol with diet and exercise and so on. He's like, yeah, sure, go ahead, try. It didn't work, right? So I take a statin. I had to find the right statin.
Right.
And I don't think it's a character flaw that I have. I think it's just a drug that really helps you. And the GLP-1s are going to help a lot of people with these comorbidities. Yeah, there's a question of cost, but if we innovate and if we drive into a space like this, we know what happens. It's like statins, right? The cost comes down a lot, but you have to do it right. And the adherence piece is absolutely critical, because if we have programs and spending without adherence, either in the private sector or in the public sector, you're not going to like the results, because it'll be about the adherence failing. Then there'll be a blowback. So it has to be done properly, carefully, it has to be measured. And we've got to capture and look at these productivity effects, both the direct ones for the individual and for companies. And then I think we're going to see the pathway forward.
And I would just say similar, I think about, again, mental health wasn't something we talked about 5 years ago. You have to talk about it as an employer now. Menopause was a bad word. Like, no one wanted to talk about menopause and the impacts of menopause on women. And that's an obligation of employers to understand what you're providing to women during the impact that has on the workforce. And so I think this is a similar situation where people need to be given the facts and the information versus basing it off anecdotals.
So lastly, Robert Kennedy is on this. We have 10,000 ingredients in our food chain, right? We have plastics, microplastics, everything. We've been poisoning. We've allowed the tobacco companies to take over the food industry in the last 40 years. We've been getting poisoned. I don't care if you're a billionaire. We're fighting science with science right now. And I don't listen to this. I don't want to hear it. The charlatans of wellness that I call it's the sword of the weak to keep telling us, just go do Weight Watchers, everything will work out, because nothing has worked. None of these legacy weight loss programs, wellness programs have worked.
We have another audience question that's again about the cost benefit here. And so Mark Hyman asking about, saying he sees about 10 to 20 cents of savings per year for every dollar spent on GLP-1 drugs. There has to be in this, as whether it's governments or whether it's employers, as we're making long-run decisions about who's going to pay for this and how much they're going to pay for it, the cost side is going to be really key to that question. So some of that is about, are there ways to draw on AI and have the administrative aspect of that be more cost effective? But a lot of that is still going to be the direct pharmaceutical cost. Is there a number, what price does this have to come down to per month for this to pencil? And say, as Simon notes, that we have a complicated payer system and it's not always the right person paying, but we have the system we live with. But is there a number that this has to get down to for that to work? Where we're going to say this is going to get thrown in with all the other pharmaceuticals, and employers and the government are just going to pay for it, and the cost is low enough that it makes sense.
I would just say I hope so.
Right, but I mean, what is that? Is 100 pounds a month is what $120? Is that low enough? Are we gonna get there?
So here's the funny part. I'm going to use the UK as an example.
Yeah.
We don't understand that we talk to NHS, and we think, people like Elon Musk would say at that price, they should be putting in bows and arrows and just shooting everybody with Ozempic. He's actually said that on stage. So even with low-priced drugs, there's obesity discrimination. At 100 pounds, they should give this to everybody in the UK who wants it. At that price point, the ROI is incredible. But it's still not happening. It's like I've told everybody, you could go offer certain people, here's $100 for a dollar bill, and a lot of people won't take the $100 bill. That's where we are with GLP-1s. I've now seen it in the UK. They have the price. They have the intellectual capacity. They're one of the greatest countries in the world, and the price is not it. When you have obesity discrimination and ignorance and people who have legacy, I don't care if they have their weight loss, their bicycle thing, the walkathons who are out there still saying, oh, drugs are bad, you should do this on your own, and it's your fault. I believe obesity discrimination, it's not the price of the drugs. I don't see that at all. It's obesity discrimination.
Simon?
I think it's going to become a cheap pill, Josh. I don't know when, right?
Okay.
Because that's a result of this dynamics we're talking about, like adoption, amount of entry, the scale, what's the business model that succeeds. But I think it's got exactly the hallmarks of what makes this industry so compelling and yet also sometimes so frustrating. You allow people to make a lot of money when they innovate, and then you push for entry, but you do let them extend patents and so on and so forth. So is it 10 years, is it 20 years before it's super cheap? I have no idea. But the dynamic is there, and also there's an adoption logic for individuals, for companies, and for some elements of government in this country and other places. So we're going to be learning, and we're going to be measuring better, and that'll help us calibrate the way forward. So ultimately, we'll look back and say, why did it take so long? Kind of embarrassing, but we'll get there.
And then the final question I want to take coming from the audience, and I want to start with Simon on this, is you opened by talking about the bending of the cost curve and how we're hitting upon a healthcare intervention that, in addition to extending life, looks like it has the potential, at least in the long run when costs are lower, to lower healthcare costs. Are there other things that you see coming on the horizon that are appealing in the same way? The questioner asks about dementia, cancer vaccines, mental health. Are there other areas that we should be looking for where we think that there might be innovation that actually saves money in addition to extending life?
Well, the one that comes up all the time, but it's somewhat magical in its discussion, is AI. That artificial intelligence will somehow change something about how we interact with healthcare. It'll change how we think about our lives, our benefits, and so on. But I think the problem with that, Josh, is almost always it's pretty nebulous still. And I think something like this empathetic AI that Michael's using, where you're not really replacing the provider with AI at all. You're putting some power in the hands of the patient. You're making it so that the patient can get access, can get advice 24/7, for example. You're making it so that you can get the drug at the same price every month easily. So it's actually, you might call it AI, but I think it's actually just making people's lives easier. The lives are the patients, the individual people. And Dr. Oz, this was, I think, the first thing he said this morning, which is he wanted to take up his current position and pursue his career, I think, because he's interested in agency for people. So people having agency relative to this extremely complex healthcare system. So I think that some elements of AI and some elements of making life simpler for people and easier to understand and helping them make their own empowered choices, that to me, not super high tech, but that I think is the right way forward.
Okay. Oh, Lisa, do you have a last
No,
thought?
I would just say that 40% of the United States is struggling with obesity. It leads to 60 other diseases. There is or conditions. There is a massive opportunity for us to be focused on that. Our population is over 50% female. And we know that it was 2016 before we even did trials on female mice. It was always only on male mice. That was 2016.
Yeah.
That was 9 years ago. So there's a lot of opportunity for us as we move forward in this next generation of health to really think about how are we holistically addressing things and making sure we're paying attention to population health and helping people to make good decisions and organizations to make good decisions.
Okay. I think we can leave it there. Thank you, everybody, for joining us, and thank you for the interesting conversation.